She's record كده.
Okay. So good afternoon, everyone. My name is Samim. I'm a resident interventional radiology, currently working at the University Medical Center in Utrecht in the Netherlands. And together with Dr. Hilar we have made a presentation about chest X-ray with a systematic approach with focus on COVID-19. That we want to present here today, and I hope that it's educative for everyone, especially for the doctors, our colleagues in Afghanistan. So the content, I will start with a little bit about the anatomy, and we will then move to systematic approach of the chest X-ray. And then finally, the chest X-ray, of course, for COVID-19 and the important differential diagnosis that you have to think of. This is a schematic drawing of the chest X-ray with delineation of the organs in the thoracic cavity. As you might recognize, of course, you have the heart, the large vessels and the lungs as well, but you also have structures outside the thoracic cavity that you have to look at on the chest X-ray. For example, the proximal part of the stomach, also the bony structures outside the thoracic cavity, the shoulders, the clavicles, and of course the soft tissue as well. This is a more detailed picture. Sorry for the Dutch translations, but I think mostly you will be able to understand most of it. So in terms of vascular structures, the aortic arch, you can see here, the vena cava superior and the pulmonary artery are important structures. Also the confluence of the subclavian and the jugular vein you might be able to see on the chest X-ray, and also the hilus, which is mainly also consistent of vascular structures as well. The heart consists of 4 chambers. You should notice that the right border of the heart is formed by the right atrium. The inferior border is formed by the right ventricle, and the left border is mainly formed by the left ventricle. And you have to notice that the left atrium is only bordering the posterior border of the heart on the lateral view. And on the frontal view, you will only be able to see a slight part of the left atrial appendage, and not the whole atrium. So moving more inwards, you see the pleural cavity consisting of the visceral pleura around the lungs, and which are the red line on this picture. Both sides, and you have the parietal pleura, which is the yellow line, and between you have the pleural cavity, and the most caudally oriented part of the pleural cavity is the pleural sinus. And the pleural sinus is the space where you probably will find the first signs of pleural effusion in, for example, patients with congestive heart failure. So if you have opacification of the pleural sinus, think of a pleural effusion. Moving to the anatomy of the lungs, starting with the right lung, you have on the right, you have the right upper lung, the right lower lung, and of course the right middle lung. And on the right, we have the oblique fissure and the horizontal fissure, also called the major and the minor fissure. And notice that the minor fissure on the right differentiates between the right upper lobe and the middle lobe, instead of on the left side, which you only have the major fissure parting the left upper lobe from the left lower lobe. And on the left side, also notice it's also the same on the right side, but you will have some overlap on the frontal view of the left upper lobe and the left lower lobe. So if you have consolidations in this area, you have to look at the lateral view as well to see whether the pathology is in the upper lobe of or the lower lobe. So that's briefly about the anatomy of the chest X-ray. Moving on to the systematic approach. Before starting with the systematic approach and to the recognizing the pathology, you also have to look at adequate quality of the chest X-ray, which is really important for example, if you have an inadequate quality of the picture, it must be really misleading for recognizing some pathology, as I will get into that later. So we will look at exposure, inspiration, and positioning. So exposure actually means that the degree to which X-rays pass through the body. This part of the quality actually depends on the radiographer, but if you have an under or an overexposed picture, you have to recognize and then you have to redo the chest X-ray probably to be able to recognize the pathology. So a good exposure means that you should be able to appreciate the thoracic spine through the heart shadow. So in this picture, it might be difficult, but you have to be able to recognize the thoracic spine through the heart shadow. So it should be a little bit more dense compared to the heart shadow. You have to be able to see the diaphragm. It should be a delineation between the diaphragm and the lung area should be sharp. Also on the other side, as you can see here, a sharp delineation between the lung area and the upper abdomen. And you have to be able to see vascularization through the heart shadow. As you can see here, small lines which are the vascularizations in the lung. You have to be able to see those in under or in overexposed pictures. You will not be able to see anything through the heart, so you might miss masses or consolidations that are posteriorly located compared to the heart. So exposure is extremely important. Another thing is inspirations. So chest X-rays are conventionally acquired in the inspiratory phase of the respiratory cycle. Sometimes it is difficult, of course, in patients who are short of breath or are not able to follow instructions to make adequate chest X-ray in inspirations. So pay attention to inspirations. Adequate inspirations means that you should be able to count 9 to 10 posterior ribs, or the diaphragm should be intersected by the 5th or 6th or the 7th anterior ribs in the midclavicular line, as you can see on this picture. So in these two cases, you have a good inspiration on the chest X-ray. So here, to just give an example, you see a chest X-ray in expiration and a chest X-ray, the same patient, same day in inspiration. As you can see, what happens in the lower zones of the lungs is really hard to tell. You might have a feeling that there is some pleural effusion or consolidations, but if you make a chest X-ray in inspiration, you see that there is actually the lung areas are really clear, no densities, no consolidations, and no pleural effusions. So inspiration is really important as well, although sometimes really hard in patients with short of breath. And also remember that chest X-rays made in expirations can be misleading. They can exaggerate the size of the heart. It might seem that this heart is too large, but if you look at the inspiration chest X-ray, it looks normal. And the bronchosvascular vessels and bronchially, they seem a little bit enlarged, but on the normal chest X-ray, you see that it also, it all looks normal, so no abnormalities. Moving to positioning, so this is important because if you do not recognize rotation on the chest X-ray, certain appearances might may become misleading. So check equal distance between the vertebral spine and the formed by the processus spinosi, and the distance between the vertebral spines to the medial clavicle. So it should be the same on either sides. Otherwise, you have to suggest rotation. So a rotation will lead to offsetting of the spinosus, processus spinosus also. So why is it important? It might also lead to misinterpretation of the heart size, the hilus, or the density of the lungs. Sometimes if there is a really, if you have a rotated chest X-ray, the posteriorly located lungs might seem really dense, and you might think of pleural effusion or consolidations. So look at this area, the clavicles and the processus spinosi. If the exposure, inspiration, and the positioning are assessed, you could move to assessment of the intrathoracic organs and evaluating them on abnormalities, patterns, and also on finally making a differential diagnosis. So every radiologist probably has a favorite approach on assessing an X-ray. I tend to start to use outside approach, starting with the heart, then a mediastinum and hilus, the lungs, thoracic wall, and at the end I look at the abdomen and all the soft tissue around the thoracic cavity. So that's my approach, but if you find a systematic approach that you like, you should use that, as long as you get to all of these organs and all of these locations to evaluate them all. So we already talked about the heart and the borders, but I will call them again, just to repeat some of the information. The orange chamber here is the left atrium. As I mentioned earlier, the left atrium is only the posterior border of the heart on the lateral view. So on the frontal view, you will only see the on the left side, the left atrial appendage. The right atrium forms the right border of the heart, the right ventricle, the inferior border of the heart, and the left ventricle, the left border of the heart. You can imagine if you have increased size of the heart, for example, enlargement of the left atrium, you might see increased size on the right side. So there is a sign, that's the double density sign on the right part of the cardiac shadow, which could suggest enlargement of the left atrium. Actually, on the enlargement of the left atrium on the lateral view is more bulging of the left atrium towards the spine, so posterior enlargement of the heart. So what is a normal size of the heart? Probably know that a cardiac-thoracic ratio less than 50% is normal. As you can see here, the size of the heart. Compared with the thoracic wall size from one side to the other side. Notice that you can only measure the cardiac-thoracic ratio on the posterior-anterior frontal chest X-ray and not on the anterior-posterior frontal chest X-ray, because on the anterior-posterior frontal chest X-ray, the heart seems enlarged because of the positioning of the heart compared to the the X-ray tube. So only measure the cardiac-thoracic ratio on the posterior-anterior frontal chest X-ray. So the contours of the heart reflect various cardiovascular components. As I mentioned, it can be enlarged, absent, or displaced. An enlarged heart and increased pulmonary vascular markings can be an indication of cardiac abnormalities, being congenital or acquired in some patients. So an important pitfall and looking at the heart and the pericardial structures is pericardial fat tissue. As you can see on this chest X-ray, it seems that there is a opacity near the right border of the heart in the cardiophrenic corner angle, also called. And you might think that this is caused by a tumor, maybe a consolidation based on an infiltration, or maybe atelectasis. But if you have a CT of the same patients, you might see that there is fatty tissue in that same area. So this is the patients just with an overload of pericardial fatty tissue. So this is a normal variant, and this is not a pathology. So this could be really difficult, but if you have previous chest x-rays, or if you have a CT scan of the same patients, it might help a lot. An important pitfall is pericardial effusion, which might be life-threatening in case of several severe pericardial infusion, which is more than 200 milliliters. It can be visible on chest x-ray. So on chest x-ray, in case of pericardial effusions, you might see an enlarged heart. And what you also can look at is widening of the subcarinal angle. It's difficult to see on this picture, but this is actually the subcarinal angle. And in case of enlargement of the heart due to cardiomegaly or pericardial effusion, this angle will be increased in size. So it can be an acute finding, and you have to have the clinical symptoms as well to find out whether it's a normal cardio enlargement of the heart or pericardial effusion. So enlargement of the mediastinum can have several causes. For example, a tumor, but also aortic dissection. In this case, this is a mass effect. As you can see, there is a deviation of the trachea, probably due to enlargement of lymph nodes, pathological lymph nodes. And in case of acute dissection of the ascending aorta, you might see a similar appearance with enlargement of the superior mediastinum. Also pay attention to sharp lucent lines. Of course, you might notice the subcutaneous emphysema in the shoulder area, in the axilla area, and also in the superior medias. But you also have to notice the sharp delineation, lucent delineation around the heart borders, which are a sign of pneumomediastinum, which can be acute in some patients, for example, trauma patients. So enlarged hilus can be unilateral or bilateral. It can be caused by enlarged reactive or pathological lymph nodes. For example, in tuberculosis, as you can see here, obviously enlarged hilus due to enlarged lymph nodes. Also, what we see in the Netherlands is granulomatous diseases such as sarcoidosis, but also enlargement of lymph nodes in malignant pathology. Also look at the hilus in relation with the mediastinum. As if you can see enlargement of one side of the focal enlargement of the mediastinum, it can also suggest enlarged lymph nodes in more proximal stations of the mediastinum. So just a quick sidestep to pediatric chest X-ray. In pediatric chest X-ray, the appearance of the thymus can be misleading. So you should be able to recognize a normal thymus, which is the triangular in configuration, mainly towards the right of the mediastinum, and a thymic sail sign, as seen on the right chest X-ray here, is the inferior margin of the triangular configuration, as I just mentioned. On the lateral view, you can see density opacifications in the anterior mediastinum, which is the normal location of the thymus. So in pediatric patients, the thymus can be enlarged, which is a normal finding. It's not caused by consolidation or a tumor. Something that might help, so the thymic cell sign, the triangular configuration, but also no mass effect. So you should be able to see normal vascular structures, bronchial structures through the thymus as well. So on the chest X-ray, lung abnormalities will either present as areas of increased density or areas of decreased density. So lung abnormalities with increased densities, also called opacifications, are most common. Can be divided in consolidations, interstitial densities, nodules or mass, and atelectasis. And all of these densities can be subcategorized in different patterns. So in consolidation, you have Lobar consolidation, you can have diffuse consolidation, and you have multifocal ill-defined consolidations. I will get back to this later on in the presentation. In case of interstitial densities, you have reticular patterns and you have fine nodular patterns. Mostly looked for in interstitial lung disease, but also in some cases of pneumonia, which I will get to later on. In nodules or masses, you have actually solitary or multiple masses, and atelectasis is a collapsed lung, as you can see on this picture. So atelectasis, interstitial pattern, consolidation, and nodules or masses. So this is a busy slide with lots of information, but basically this table or flowchart demonstrates the pattern of consolidations and the differential diagnosis. So just be aware that some diseases can have more than one pattern. For example, Lobar pneumonia can be focal, but it can also, in a later course of the disease, or if the disease progresses or does not respond to treatment, can be a more diffuse multifocal disease. So this table might help in differentiating if you see a consolidations. So recognizing a consolidations and the location of it can be difficult, but you have to look for a silhouette sign, which means that a silhouette sign actually means that two adjacent structures that have the same density cannot be differentiated from each other. So here you see an example. On the left, you see that you are not able to delineate the left border of the heart because of an opacification. So if you remember that the lingula of the left lung is adjacent to the heart, then you will be able to say that the opacification or the consolidation is probably in the lingula of the left lung. As in the other case, where you are able to see the left border of the heart and still have consolidation. So you know that this is a consolidation in a part of the lung that is not adjacent to the heart border. So this might be in the left lower lobe. So this is the first example, the left picture. So you have consolidations. You are not able to see the margins of the heart. So this is a consolidation in the lingula. And you have the second example where you are able to see the left border of the heart. You still have a consolidations in the left lung. But if you look at the lateral view, you see that the consolidation is more posteriorly located. So it's in the left lower lobe. Another example of the silhouette sign, a normal chest X-ray where you can clearly delineate the right border of the heart. You have a consolidation adjacent to the heart, so probably this is in the middle lobe, consolidation in the middle lobe, probably due to infectious cause. So one thing that I often hear from clinicians is whether we are looking at a consolidation or atelectasis. So it might be really difficult to differentiate, but look for signs of an air bronchogram. So an air bronchogram is seen in consolidations, but is usually not seen in atelectasis. In consolidations, you have no or minimum volume loss, whereas in atelectasis, you have a lot of volume loss because you have collapsed lungs. So that leads to elevations of, for example, the hilus, but it can also elevate the fissure, as you can see on this chest X-ray. The horizontal fissure is moved upwards, and you can also see upward movement of the diaphragm in case of atelectasis, which is not seen in consolidation. Let's see here, this is a chest X-ray in the middle with also atelectasis in the middle lobe. You see that this is not a correct border of the right heart. You don't see the normal cardiophrenic corner angle as you might usually see. So there is a volume loss. I don't have a lateral view of this chest X-ray, but you probably would see it in the lateral view as well. This is the normal case after atelectasis was healed. You see the normal delineation of the right border and the diaphragm, a normal cardiophrenic corner. This is an example of a Lobar pneumonia, and you see that it's probably difficult to see, but there are some air bronchograms. And you see that there is minimum volume loss, more expansion of the consolidation. You see bulging of the fissure. So this is a typical example of consolidation and not atelectasis. So pleural opacities, they can have different causes. Mostly pleural effusion, which most of you might have seen during your work, but also fluid collections can be formed by hematomas or empyema. If they are multiple pleural opacities, think of pleural plaques. I don't know how if you have seen those in your patient population, but in the Netherlands we see well, we usually see patients with pleural plaques, mainly due asbest-related causes. Also, remember that multiple fluid collections can be located pleural effusions. I will show an example later on. So this picture just shows a relation between the amount of fluid, pleural effusion, and the opacification on chest X-ray. In case of a large volume, entire hemithorax can be opacified, as you can see here. So with large volumes, I mean 5 liters or more. And as I mentioned, so multiple loculated fluid collections can be entrapped fluid in the fissures, for example, or other areas of the pleural cavity. So this can be misleading. I can imagine that some clinicians might think that this is a tumor mass, but if you treat these patients, then you might see that the abnormalities disappear. So we now arrived at the thoracic wall, meaning assessment of the bony structures or on mineralization, congenital or traumatic abnormalities of the bony structures, but also abnormal bony lesions. And you also have to look at soft tissue always. Look for symmetry, look for pleural thickening, calcification, of course, and foreign bodies, if you see any. So these are some pitfalls that I run to often. This is one that I hear often from clinicians. I can imagine that this density, mostly in the right or the left upper lobe, is mistaken for a mass or a tumor or something else. But this is actually a normal costochondral transition. If you look closely, you might see translucent line between, which is actually the joint. If you look at the other side, you might see something similar as well. So in this area, a density mainly around density is mostly the costochondral transition, and it's not a tumor or something else. It might help if you have previous chest X-rays to compare. If it doesn't grow, then it's not a tumor mass. Another pitfall is abnormalities of the chest thoracic wall. You see here normal varieties, is the pectus excavatum. You see that the thoracic wall is moved inwards, and on the frontal view, you are not able to see the right border of the heart. The heart might be shifted a little bit towards left. This is normal finding in pectus excavatum, so be aware. And another question that asked often is, if you see density in the pleural sinus posteriorly or on the frontal view as well, it might be caused by herniation of the diaphragm with herniation of the fatty tissue, intra-abdominal fatty tissue. This might look like a tumor or pleural effusion, but if you see this on every picture and it looks the same on every chest X-ray, then it's probably a normal finding and might be a diaphragm herniation. So always look for abnormalities of the diaphragm. Elevated diaphragm can be caused by a problem of the nervus phrenicus. It can be caused by atelectasis, as we talked about earlier. It can also be caused by high intra-abdominal pressure. A low position of the diaphragm, it can be caused by shortness of breath. It's often seen in patients with chronic obstructive pulmonary disease. And remember that the delineation of the diaphragm is normally really sharp. So blurring might result in pleural, might be a result of pleural effusion, atelectasis, or consolidation. So it's not normal to not be able to delineate the diaphragm normally. Finally, in the last step, you should look at the upper part of the abdomen for example, for enlarged bowels or free intra-abdominal air. Sometimes in postoperative patients, you might see a little bit of free intra-abdominal air, but obviously this amount of free intra-abdominal air is abnormal. It might be a sign of, for example, perforation of the bowels. Also look for foreign bodies. So next part of the presentation is the chest X-ray for COVID-19. So I have to start with mentioning that the chest X-ray only has a low or a limited sensitivity and specificity in the early stage of the COVID-19 pneumonia. There is, however, an important role in the evaluation and the follow-up of the disease. And I think it's the most important thing is to recognize airway opacifications that is suspicious of pneumonia, firstly, and then to differentiate from other clinical diagnoses with help of the clinical symptoms. And so we will now move onward to the chest X-ray signs of different types of pneumonia to help to differentiate between those. And I will close with the important differential diagnosis of diffuse airway opacifications, which is congestive heart failure, which we see often as well. So if you look at most textbooks, pneumonia is categorized in Lobar pneumonia, Bronchopneumonia, and interstitial, or also called atypical pneumonia. So in Lobar consolidations or pneumonia, is this the result of disease that starts in the periphery and spreads from one alveolus to another through the pores of cone. And at the borders of the disease, some alveoli will be involved, while others are not. So that creates an ill-defined border. So as the disease reaches the fissure, this will result in a sharp delineation, as you see on this chest X-ray, since the consolidation will not cross a fissure. So as the alveoli that surround the bronchi become more dense, the bronchi will become more visible, resulting in an air-broken cramp. So we have diffuse consolidation. We have sharp delineations of the consolidation as they reach the fissure, and we have the air bronchogram, which is really not appreciated on this chest X-ray, but in most cases you will be able to see an air bronchogram. The pathogens that are mainly causing a Lobar pneumonia are bacterial pneumonia. This is an example of the air bronchogram here, better seen on this chest X-ray. As you can see here, you can see the consolidation ill-defined on the border. So this consolidation has not reached the fissures, but it's more ill-defined consolidations with the air bronchogram, which is seen, which is really good seen on the frontal chest X-ray. So bronchopneumonia starts in a different pattern. It starts in the airways as acute bronchitis. Then on the chest X-ray, you will see ill-defined densities. Eventually, there might be progression into diffuse consolidation. And usually the disease does not cross fissures and starts in multiple segments. So pathogens can be bacterial, viral, or fungal. And here are some examples of chest X-ray in patients with bronchopneumonia. This is, as you can see, bilateral disease with, in several segments, ill-defined consolidations. On the right chest X-ray, you see mainly on the right side, but more like as well as the right upper lobe as the right lower lobe, you see consolidations, and also on the left lower lobe, you see that there is increased density behind the shadow of the heart. And in this last case, in the upper picture, there is progression into diffuse consolidations. And these consolidations, you might be, these might mimic COVID-19 pneumonia, given that there are bilateral diffuse consolidations in multiple segments, which is also seen in COVID-19 pneumonia. So this can be mistaken for COVID-19 pneumonia. So the term atypical in atypical pneumonia does not only refer to the atypical pathogens, but also the atypical interstitial pattern of the disease. So usually the pathogens are viral pathogens, but also mycoplasma infections. And on chest X-ray, you can see bilateral patchy opacities, and main findings are ground glass opacities, which are a sign of interstitial opacifications. This is also mainly seen in COVID-19 pneumonia. And I think this is a chest X-ray of a patient with atypical pneumonia in the early stage of the disease. Might be really difficult, but you should be able to see, well, you see ill-defined patchy consolidations, ground glass opacities here as well in the left lungs. So bilateral consolidations and ground glass opacities based on atypical pneumonia. So although differentiating between bacterial and viral cause of pneumonia is not always easy, there are some signs to think of. Viral pneumonia is, for example, more often bilateral disease, and bacterial pneumonia is usually focal consolidations, or you can also look at bulging fissure for a sign of expansion consolidation. So COVID-19 pneumonia, it is a viral pneumonia, as I mentioned, a form of typical pneumonia. Well, there are not really specific signs, but if you look on chest X-ray in the later stage of the disease, you might see bilateral multi-lobar consolidations or ground glass. And ground glass opacifications, as I will show later on, are really difficult to recognize on chest X-ray. But you might be able to see them. I will show an example later on. The opacifications are located mainly in the periphery of the lungs, and there is a predominance for the lower zones of the lungs. And the most extensive findings are after 10 to 12 days. So that's also the timing that we will be seeing the most extensive signs and abnormalities on the chest X-ray. This is a table which is actually made for CT changes over time, but as you can see in the early stage, day 0 to 4, you only have ground glass opacity, some crazy paving, which is thickening of the interstitial lines, and lower number of involved lobes, of course, which makes it really hard to see any abnormalities on chest X-ray. And after day 10 to 13, you might see consolidation, which are also depicted on chest X-ray. So this is an example just to show you how difficult recognizing the opacities or the ground glass opacities might be on chest X-ray. This is a patient with COVID-19 in the early stage of the disease. You see opacification, and this is mainly ground glass opacifications in the lower lobe on the right side. Maybe some bronchial consolidation, but it's really minimal and mainly ground glass opacities. And if you look at the chest X-ray, you see a normal chest X-ray, and basically, if you only look at the chest X-ray, you might not find any abnormalities. This is another chest X-ray, same day as the CT scan. You see on the CT in several levels, you see ground glass opacities, only ground glass, no consolidations. So these are all ill-defined, patchy, multifocal, bilateral ground glass opacifications. And if you look at the chest ray, you won't recognize any of them. Maybe you would hesitate about what happens here, but I would really say that this chest X-ray is normal. So this is an example where you might be able to recognize ground glass opacities. Chest X-ray is made on the same day as the CT scan. As you can see, there is more diffuse ground glass opacities, more lobes are, the disease is in more quadrants, also in both lungs. So if you look at the chest X-ray, you see ground glass opacities in the periphery of the, actually I would say only on the left side, which correlates well with the coronal view of the CT scan here. So if you see peripheral oriented ground glass opacities, might be difficult, but if you see them bilaterally, you see them more in the periphery, more in the lower zones, think of COVID-19 if you don't have access to other tests or CT scan. So obviously this is an example of a more extensive disease. Typical findings in COVID pneumonia are ground glass opacities, as you can see here. You also see some consolidations here depicted by the arrows. You see that the subpleural space is spared in most cases. You see peripheral orientation of the consolidations, and if you look at the chest X-ray, you see the same consolidation as seen on the CT scanner. So in more severe cases, you will be able to recognize the bilateral, peripheral located consolidations and ground glass opacities. Okay, so recognizing COVID-19 pneumonia on chest X-ray is difficult. So in the early case of the course of the disease, it might be really difficult, but in the later course, in more extensive disease, you will see findings of COVID-19 on the chest X-ray as well. So, but if patients present with diffuse abnormalities on chest X-ray, as we have seen earlier, it is also important to differentiate between other diseases. And congestive heart failure is one of the #1 differential diagnoses that we see quite often. So I will get to that as well. So congestive heart failure is the result of insufficient output because of cardiac failure, high resistance in the circulation, or fluid overload. So the left ventricle failure is the most common and results in decreased cardiac output and increased pulmonary venous pressure. In the lungs, left ventricular failure will lead to dilatation of the pulmonary vessels, leakage of pulmonary fluid into the interstitium and the pleural space, and finally into the alveoli, resulting in pulmonary edema. So signs of congestive heart failure. I think this is an important picture where you can see all the signs that you might see on the chest X-ray. You can see a vascular pedicle, increase of the vascular pedicle due to fluid overload. You can see pleural effusion. You can see redistribution of blood in pulmonary vessels, which is caused by distension of the vessels, mainly in the upper zones, and also recruitment of the previously non-perfused vessels caused by calling of the caused by the reserve capacity of the lung. So all the non-perfused, previously non-perfused vessels might be open as well. And you can see pulmonary edema, which is caused by leakage of fluid into the alveolar space, and you can see curly lines, which is caused by leakage of fluid into the interstitium, which is caused by, for example, a thickening of the interstitium interlobular septa. This picture, it might be hard to recognize, but at least you can see pleural effusion. You can see some increasing of the pulmonary vessels in the upper zones. You don't see much pulmonary edema, or there is probably no alveolar leakage yet, because that's one of the last stadium in congestive heart failure, but you see some signs. So there are some curly lines as well. See here the curly lines. I will have better examples later on. So the vascular pedicle is an indicator of the intravascular volume. The vascular pedicle is the borderline on the is bordered by the on the right by the superior vena cava, and on the left by the left subclavian artery origin, as you can see here. And a vascular pedicle width of more than 85 millimeters is pathological in 80% of cases, and a 5 millimeter increase in diameter corresponds with a 1 liter increase of intravascular fluid. In this picture, the red arrow depicts the vascular pedicle. See that it's a bit enlarged compared to the normal chest X-ray in the same patients. And the blue arrow depicts the redistribution side. You see distension of the vessels in the upper zones. If you compare those with the normal chest X-ray, you should notice that there is enlargement of these vessels. There are more vessels as well. We talked about curly bay lines, which is caused by leakage of fluid into the interstitium due to pulmonary edema. This is a better chest X-ray for depicting the curly bay lines. You see here the lines that I was talking about, mainly seen in the lower zones of the right and the left lungs. Mainly in the pleural sinus, and these lines are mainly 1 to 2 centimeter. You see here several curly bay lines. This is the normal chest X-ray of the same patient. So curly bay lines can also be seen in a malignant cause, also obstructions of lymph nodes and pulmonary fibrosis. So it's not a specific sign for pulmonary edema. So there is fluid leakage into the peribronchosvascular interstitium, leading to thickening of the bronchial walls, which leads to peribronchial coughing, as you can see here. All these densities around the hilus. And there is loss of definition of the peribronchial vessel. So if you look at this chest X-ray, you won't be able to delineate the vascular structures here. So one of the last stages of congestive heart failure is alveolar edema, which is seen here, mainly oriented in the central zone, so around the hilus. And you have to look at the whole picture. So if you have consolidations bilaterally, mostly oriented around the hilus, you have pleural effusion, and you have curly lines, and you have an enlarged heart. So this is obviously a patient with congestive heart failure. There are no signs of pneumonia, so this should not be mistaken for a COVID-19 infection, but it can be really difficult to differentiate in some patients. Another thing that helps is a follow-up chest X-ray. If you have a patient with congestive heart failure and you start with treatment, for example, with diuretics, and you repeat the chest X-ray another day, you see clear lungs, you see decreasing of the pleural effusion, and you see that the pulmonary vessels are normal in size. So this was a case of congestive heart failure. So this is my last slide. Some key points to think of. We started with anatomy. This is really important. Just know your anatomy when you're looking at chest X-ray. Second point is adequate quality of the chest X-ray before starting with examination and assessment. Look at exposure. We talked about positioning and inspiration. And we talked about the low sensitivity and specificity of chest X-ray for COVID-19 pneumonia in the early stage of the disease. But remember that chest X-ray can be really valuable for follow-up of the disease and also in the later stages of the disease. And we talked about other types of pneumonia which can mimic COVID-19, for example, atypical pneumonia and more progressed bronchopneumonia, and also talked about congestive heart failure as important differential diagnosis. So are there any questions?
No questions, I guess.
No questions? Anything from Facebook or
No
messages?
No, we are not on Facebook.
No, we're not on Facebook.
We will post it later on Facebook. Thank you very much, Marcel, for your presentation. I think
no problem.
I learned a lot myself. But I would like to say I didn't do it in the beginning of the presentation. We will have every 2 months we will have a presentation, and Marcel is one of the radiologists, resident radiologists who will give the presentation, and Dr. Hilar, but he will do next. In the next presentation he will be preparing it. I don't know if anyone has a question. We can also carry on with speaking in Farsi, so that's also okay.
Yeah, اگه سوال به فارسی هم هست میتونین سوال کنید. And I will just, Rasmajan, the presentation can be shared with everyone.
Therefore, we will post the video and the presentation online.
Yeah, I can make a PDF of the presentation.
Great.
And
Yeah, we will post it on our website. So if anyone wants to watch it later on, it will be available on our website.
Okay.
I have one question. Do you have my voice?
Yes.
Hello, how are you to all regarding? My name is Muhammad Arif, and I'm a medical director in the COVID-19 hospital in Province.
Yeah.
I have a question that's contained. What is the most difference between COVID-19? What is the most different between the COVID-19 or another viral or bacterial pneumonia? Just exchange.
Yeah, it's a good question, but it's really difficult. As I showed, the COVID-19 pneumonia, it's really a typical, another atypical pneumonia. So the signs of atypical pneumonia are really brought on chest X-ray. So you might have some patients with influenza, which is a viral pneumonia. The same signs you will see in COVID-19 patients on chest X-ray. So there are really no specific signs that will help you differentiate between one viral pneumonia compared to another viral pneumonia being COVID-19.
Okay, thank you so much.
No problem.
Are there any other questions?
دکتر صاحب مرسل جان ما یک سوال داشتم در قسمت از اینکه تغییراتی که در چست اکسری از باعث کووید 19 اسوسییتد نمونیا به وجود میاد زمانی که نمونیا دوباره ریزولو میشه و شخص ریکاور میکنه آیا بعد از او هم کدام تغییری در چست اکسری از اینا باقی میمانه یا که دوباره چست اکسری کاملا نرمال میشه؟ مثلا مریضایی که تا یک اندازه میگن در کووید 19 نمونیا ریا به طرف فبروز شوشا به طرف فبروز میره آیا تغییرات فبروتیک میمانه که در چست اکسری قابل دید باشه یا که کاملا دوباره ریزولو میشه به حالت نرمال؟
بله خیلی سوال خوب. ما تا حال زیادتر مریضای کووید 19 چست اکسریشن که میبینم بیخی نرمال میشه چست اکسریشن، اما همونطور که گفتم interstitial abnormalities که پیدا میشه بعد از کووید 19 بعضی مریضان مثل خودتان درست گفتین فیبروز پیدا میکنن و در چست اکسری شاید یک کم ساین از فیبروز ببینن مثل interstitial. باشه ببینم من یک عکس دارم از یا نه. حالا یک اکزامپل خیلی خوب ندارم ولی فیبروز به چست اکسری مثل interstitial disease است. بعضی چیزایی که مثلا میبینی است که بعضی خطایی که در چست اکسری میبینی یا شاید کمک زیادتر بشن و I think it's difficult to see subtle signs of fibrosis after COVID-19, but sometimes you might be able to see differences post-COVID chest X-ray and pre-COVID chest X-ray. If you see some thickening, for example, thickening of the interstitial spaces, so some lines. As I mentioned with the curly bay lines, I think I had here, as I mentioned with the curly bay lines, it's also a sign of pulmonary fibrosis. So you might see more curly bay lines, so thickening of the interlobular septa. So that might be a sign of interstitial disease, which is also a sign of fibrosis in some patients with COVID-19. Some patients with COVID-19 also have some rest abnormalities at the end of the disease course. They might have some rest ground glass opacities. So it starts with ground glass opacities. It will progress to consolidations, and you might end up with some ground glass opacities at the end, which are actually sign of interstitial disease. And eventually, if you have if you're left with fibrosis, you might see some signs of that on chest X-ray. But I think it will be really difficult to recognize it on chest X-ray compared with CT. So,
thank you so much for your nice presentation.
Yeah, you're welcome. I see Parvis is online. Any questions, Parvis John?
We just got on the line.
Oh, you just got on, okay.
With Dr. Ramin Faramars from Afghanistan normally, but now he's our guest.
I heard. Okay, welcome.
Thank you. We will follow.
Okay. خب خلاص شد دیگه. پرویز جان دیر آمدی.
No problem. It has been recorded, so we are going to watch it again.
Rasmujan has recorded it, so
yeah,
you can watch it again.
So if there are no questions, should I end the And presentation or no questions, right?
Yes, I will stop sharing now. So there you
Okay,
go.
great. Yeah. So if there's no questions, I will stop the record and then also stop the presentation.
Okay.
Yeah. Okay. Thank you very much, Marcel. It was a clear presentation.
Thank you for listening.
As I said, it was really, I learned a lot myself. So yeah.
Yes, thank you all.
Okay.
And hope to see you next time.
Yeah. Bye-bye.
Bye-bye.